So good morning. And welcome to the 2017 Annual Research Meeting, or as we all like to call it, the ARM. This is our 34th ARM and our first ever in New Orleans. Now, yay. Now, most of you don't know this, but we select the site for each meeting at least 6 years in advance. So that means that even though this is my 7th year as the president and CEO at Academy Health, it's sort of like my first ARM because it's the first time I had a chance to pick the location. And I couldn't have known it 6 years ago, but it turns out that this amazing, historic city is actually a perfect backdrop for our meeting this year. And not just because the food, music, and architecture are amazing, although of course they are, and I hope you get to enjoy them at night, not during the meeting. The reason I think it's a perfect backdrop is because in a year of tremendous change and uncertainty in our field, New Orleans can be an inspiration for our future. New Orleans reminds us of the ingenuity and resilience of people tested over and over again, and the power and beauty born of bringing diverse cultures and ideas together. As Mayor Mitch Landrieu so beautifully stated in a speech earlier this year, New Orleans is truly a city of many nations, a melting pot, a bubbling cauldron of many cultures. There is no other place quite like it in the world that so eloquently exemplifies the uniquely American motto, E pluribus unum. Out of many, we are one. Out of many, we are one. I want to focus on that for a moment and talk about what it means for us here this week. Over the last year, I've been talking a lot about the unique challenges facing our field and the VUCA world we live in. VUCA, volatile, uncertain, complex, and ambiguous. This new world we're operating in is full of disruptive change, not bad or good in of itself, but it's all around us. We're dealing with new data and the emerging methods and governance necessary to fully realize their potential. The funding environment, in terms of both available funds and the focus of funders' interests, is changing. And a new administration is proposing dramatic changes to a health law, the impact of which we have only begun to document. Where do we find solid ground amid all these forces? How do we stay true to our mission as an organization and as a field? And where do we go to find inspiration? The answer, I believe, is here at the ARM. The ARM is a chance to recenter ourselves professionally, to reconnect with colleagues who share our passion for evidence and policy, to learn about new research, new data and methods, and yes, to make connections with funders and potential collaborators who support our work. Over the next few days, we'll talk about the VUCA world we live in, sure. In fact, this morning's opening plenary dives right into what we can expect from health policy in Washington post-election. We have sessions on the research agendas of the major federal agencies and meet the editor sessions to talk about how to disseminate your great work. And later today, I'm co-hosting a town hall session with Academy Health's Washington representative, Emily Halubowicz, about the specific challenges facing our field in Washington right now. But we'll also recognize the amazing work of our distinguished investigator and other annual award winners. We get to celebrate landmark anniversaries, such as the 50th anniversary for the HSR Journal and the 20th anniversary of the State Child Health Insurance Program, among others. We will explore the findings of more than 2,300 research projects submitted through the call for abstracts and connect and mentor the next generation in a number of student-focused events. And we do so, as we do so, we remember the visionaries and leaders who are no longer with us. We remember the contributions of Robert Kane, Dorothy Rice, Ken Arrow, Linda Bilheimer, Jim Mays, and Harrison Spencer, among others who passed away this past year. Together, they leave a legacy of excellence that inspires us all, and we continue our work better prepared by their example, their leadership, and contributions. Finally, and perhaps most importantly, here at the ARM, we will be challenged by our peers to engage in a productive exchange of ideas. Health services research and health policy are not the domain of a single discipline, a sole ideology, or a particular political perspective. Our ability to explore and address the challenges facing healthcare and healthcare systems in this country is made stronger by actively seeking and welcoming a diversity of training, perspectives, and lived experiences. Our call is not to consensus, but to a deep investigation into cause and effect, to a fuller understanding of options and consequences, both intended and unintended, so that decision makers at all levels and in all settings can make better choices and achieve better outcomes in this always complex and right now pretty unpredictable world. Whatever our many backgrounds, when it comes down to it, we are one in our commitment to the production and use of rigorous and timely evidence to improve health and healthcare. E pluribus unum. Out of many, we are one. This meeting is a unique annual opportunity to blend the gifts and talents of many, building and rebuilding our collective understanding of the ways our health system works and doesn't, for whom, in what ways, and at what cost. Amid the many ideas for improving health and healthcare in this country, we come together as one at the arm to learn, grow, and connect. So welcome to New Orleans. Now let's get started. So it is my, oh, yeah, okay. So now it is my distinct honor to welcome Dr. Giselle Corby-Smith, who is the 2017 ARM Planning Committee Chair. Now, if you don't know Giselle, you should make a point of meeting her. She's amazing. Dr. Corby-Smith is professor of social medicine and medicine at the School of Medicine, in case you didn't get it, something to do with medicine, at UNC Chapel Hill, and nationally recognized for her scholarly work on the practical and ethical issues regarding the involvement of minorities in research. She directs the program on health disparities at the Cecil G. Sheps Center for Health Services Research at UNC Chapel Hill. She also serves as the director of the North Carolina Translational and Clinical Sciences Institute's Community Academic Resources for Engaged Scholarship Services, or CARES. The CARES services engages communities, faculty, and healthcare providers as partners in clinical and translational research, and ultimately transforms the way that academic investigators and community members work together while boosting public trust in research. Welcome, Giselle.
Thanks so much, Lisa, for that really kind introduction. So welcome to New Orleans. New Orleans has given so much and provided so much for the tapestry of this country, and really enhanced the way we live in this world. It's the birthplace of jazz, the seat of remarkable ethnic and racial diversity, and of course, as has been mentioned, amazing food. And I'm sure that if you haven't already, you'll be partaking of it shortly. However, New Orleans, in particular, really provides this example of resilience after Hurricane Katrina. It's been recognized by nationally and internationally as one of 100 resilient cities. It also has, and we had an opportunity yesterday to visit the VA and see physical evidence of the transformation of the healthcare system here. It was an amazing tour of this new facility that not only is refigured and reimagined to better serve our veterans and our servicemen and women, but also to provide a safe haven for New Orleans in times of disaster. So why the ARM? As Lisa mentioned, there has been unprecedented national attention on healthcare reform and funding for research. And what's remarkable to me is that this attention is not just amongst us who study this and do this for the work have been doing this for years, but it's amongst our patients, it's amongst our clinical colleagues who really are engaged in this dialogue in ways that I have never seen in the past 25 to 30 years that I've been doing this work. It's asked us to really imagine sort of the state level policy implementation with greater emphasis, as well as been mentioned, uncertainty locally for what that means for us as researchers. But it also provides this amazing opportunity for health services researchers to inform the policy dialogue. Yesterday at some of the poster sessions, it was already so much of what has already been done can inform the dialogue that we have going on now in our country, even at the rapid clip that it's changing. And importantly, it's an opportunity for us as investigators to understand the impact for our patients, for providers, for payers, for academic centers, and for the healthcare systems in which we all work and who we hope to serve with this work. So a few ARM highlights. We have more than 2,500 registered attendees and continuing to meet and exceed the benchmarks that we had hoped for this meeting. 150 sessions with over 600 faculty, 1,250 poster sessions, and more than 2,400 abstracts have been submitted. My job here is to make sure that our sponsors who have been fundamental in this work are recognized, and you can see we have a list of sponsors here. And then finally, to thank the Planning Committee, my colleagues who were willing to join me in this quest to provide this meeting to you. Importantly, I also want to thank the Academy Health staff. As I've told the incoming chair, this is the best job that I could have had. The team that works with us at Academy Health is incredible. And so thank you.
Bit of a height difference there. So thank you, Giselle. Now we're going to begin this morning with a facilitated conversation discussing health policy after the election. What can we expect, and what will be the role for evidence? So I get to introduce the moderator, who will then lead us for the next several minutes. So Dr. Joe Thompson is President and CEO of the Arkansas Center for Health Improvement and professor at the University of Arkansas for Medical Sciences. Joe's work is centered on the intersection of clinical care, public health, and health policy, and he is responsible for developing research activities, health policy, and collaborative programs that promote better health and healthcare in Arkansas. He has led vanguard efforts in planning and implementing healthcare financing reform, tobacco and obesity-related health promotion and disease prevention programs. He has worked with Arkansas's executive and legislative leadership and the U.S. Department of Health and Human Services. In addition, he is guiding Arkansas's innovative initiatives to improve health system access, quality, and cost, including a systematic multi-payer overhaul of Arkansas's healthcare payment system. And he's an alumni of the Academy Health Board. So please join me in welcoming Dr. Thompson to the panel.
Thank you, Lisa, and thank you for the Planning Committee and our host here in New Orleans. It's an honor. I want to ask our panel to come up and join me. We're going to have an exciting kickoff to our meeting today. You know, I was thinking as I tried to figure out how we were going to start off, there is a buzz in the air. Please come up. Yeah, please come up. There's a buzz in the air because of the timing of this meeting. And I went back to Dickens' statements. It was the best of times and the worst of times. And actually, if you haven't gone through the rest of that quote, it's important. It was the age of wisdom, and it was the age of foolishness. It was the epoch of belief, and it was the epoch of incredulity. It was the season of light, the season of darkness, the spring of hope, and the winter of despair. But that doesn't really fit because we're challenged by our social and moral responses to our political process. But this is the research meeting. This is where knowledge and science gets generated and disseminated. So the more apt application, as I thought about it this morning, was Horton Hears a Who. We are the Who's in Whoville, and we have to get our message out. So Lisa didn't say it, but your hashtag #ARM17 is an important way to get your message out for those of you that are adept at that. Our publications are important ways to get our messages out, and we're going to have an important dialogue here about how to insert the art of science into the policy dialogue to hopefully help lead our nation in a direction that better serves its citizens and leads to a place for the future. So I'm excited to sit down and introduce, from my left, Adeze Enekwechi, Vice President of McDermott Consulting. She's the past Associate Director for Health Programs at the White House Office of Management and Budget. To her left, Joe ANTOS, who is the William Taylor Scholar in Healthcare and Retirement Policy at the American Enterprise Institute, and importantly, past Assistant Director for Health and Human Resources at the Congressional Budget Office. And finally, from the private sector at the end, Reed TUCKSON, who's now Managing Director of the TUCKSON Health Connections Corporation, but formerly was Executive Vice President and Chief Medical Officer for a long term at United Health Group. So welcome, thank you. What we would like to do is engage in a dialogue with you. We will have our panelists speak for a few minutes each. We'll have some questions and answers here. And then at the last half of our session, we hope we can engage with you at the mics. So be thinking about what questions you would like to ask of our panelists here this morning. So Adeze, why don't you start us off?
Thank you, Joe. Good morning, everyone. In early June, when I started to think about what I would share with this body, the Senate was deliberating whether they would bring a vote to the floor on a health care bill and how much of the House's AHCA bill, especially the portions dealing with Medicaid and other coverage protections, will be included in their repeal bill. Well, as of a few days ago, we now have our answer. And I knew back then, this is 3 weeks ago, that whatever I was thinking in early June would likely be moot by the end of June. And frankly, the politics of healthcare change, at least in Washington, D.C., by the day, sometimes by the hour. And I know with certainty that this is no way to run a significant portion of the economy. Huge shifts in momentum and ideas, from moment to moment on such an important and sprawling policy issue that often affects people who are sick, who are poor, or sometimes all of the above, and often the most vulnerable in our society. However, health services research predates this current political climate and will be around long after the dust settles. So as a health services researcher and a policy leader, I want to focus my comments on these very issues, our longevity and our relevance in the policy debate for the foreseeable future. First, the role of research and science. The Academy Health Body must continue to insist that healthcare research funding be made a central policy focus in the coming years. This includes NIH and AHRQ and the myriad other agencies that support healthcare research. The giant steps we've taken as a country in studying disease, patient safety, organizations, social determinants, health equity, to list just a few, were possible because we had the funding. We have much progress to make, of course, in our ability to support a new generation of researchers who will study the diseases and the contexts of tomorrow. And we have some room for improvement in linking our research agenda with the relevant and current policy questions of the day. But without resources to support the advancements we are yet to make in solving these big problems, we would essentially stop midstream, having identified many problems but not close to solving them. And I don't think this is where we want to be. The second point I'd like to make is that we can no longer afford to separate policy and policymaking from research and evidence. At OMB, with budget and policy responsibilities that covered all domestic health programs in the last 2 years of the previous administration, my perspective as a health services researcher fit well with how we thought about allocation of resources based on evidence. We asked hard questions and brought rigor to our policy considerations. We did not get it right all the time, but we now know not to take for granted the role of evidence in policymaking. As we begin to move the needle on areas like population health and devise new methods, drugs, or technologies for engaging consumers, We must build evidence into our conversation, and we must make the case that our innovations work, as well as we make the case that they should be covered in our evolving payment policies. Our job is to be at the policy table, the policymakers table, both at the state and the federal level, with actionable evidence from our research. In my opinion, the long game is better than the short game if we are truly interested in improving healthcare quality and outcomes. The near-term games are messy and at times depressing, but an appreciation for the long game, and by that I mean the role of evidence, data, its proper collection, painstaking analysis, and accurate conclusions, and infusing all of these facets into the policymaking arena, this is what will have an enduring impact and positive impact on our healthcare system. Thank you.
Thank you, Adesi. Joe, why don't we go to you?
Thanks very much. That was a great statement. I agree with everything you say. You know, Donald Trump came into Washington saying he was going to drain the swamp, and what Anais pointed out from the perspective of OMB, but it's true generally, is that the swamp is pretty deep, and you really can't drain it. And I might add that you are part of the extended swamp. So try to keep your croaking down to a minimum. Look, I'm an economist. I can't help it. Anyway, so what can we expect? Well, one can have views about whether some version of the Senate bill might pass, but one thing you can count on is that legislation of any sort is only the first step in a long and usually painful process to implement any kind of policy. And so, in fact, it is the implementation process that needs to be focused on. There's way too much pointless discussion about what are really supposed to be internal debates in the Senate that really don't serve Republicans or anybody else well, at least if you want to get some kind of an agreement that's reasonable. That doesn't serve that kind of process very well to be too far in the public. Now, I'm, of course, excluding tweeting. I think tweeting is a very important activity, but if you really want to make a deal with somebody, you do not announce to the Washington Post what your position is. You make that deal, and then you lock arms and say, hey, we got this thing, whatever it is. So I'm frankly very skeptical about these complaints about secrecy. There's plenty of secrecy in all good policy until, of course, you figure out what it is, in which case then you can and should be public about it. And even when you think you've got the policy, well, guess what? In the implementation process, you find out things you never knew, and it changes. So whatever might be voted on, whatever month that might be, don't conclude that the world has come to an end. Don't conclude that you don't have a role in the future, because you certainly do. In fact, more so than if everything were to stay the same. Because in an era of major policy change, even policymakers who you don't have regard for, but especially the people you don't know at the lower levels, including people we've worked with, will be looking for your advice, your technical advice, not your political opinions. That's going to be very, very important. Okay, so what's the major challenge here? Well, it was called the Affordable Care Act, but the word affordable meant that we were going to have somebody else pay for somebody's health insurance. And there's certainly a role for that. But over the long run, we can't sustain that position. We really do have to find a way to slow the growth in health spending in ways that focus on efficiency and effectiveness, and not just uninformed program cuts. The Medicare program has a long, long history of payment reductions that are loosely tied to an adjective, but not necessarily closely tied to efficiency or effectiveness. That's the easiest program to talk about because that's really a federal program. But that does characterize a lot of policy making at all levels in terms of at least federal and state programs. So that's an issue. We clearly don't have an option to stay on the current spending path. Speaking as a representative of the leading edge of the baby boomers, when we get to be 85, we're going to be spending money like nobody's business. And you younger people out there better be saving up. So we've got about 10 years to try to really address at least the Medicare issues. And as Medicare goes, I think so goes the rest of the health system to some extent. So I think it's a big, big issue. And that's a big research issue. If we had the answers, they would have been implemented. And they wouldn't have been implemented by government. They would have been implemented by the private sector. So clearly, we don't have the answer, and there's no the answer. There are a series of possible hypotheses that we're going to test out over, well, for the rest of eternity, basically. Because whenever you solve one thing, you've discovered that you've messed something else up. The other aspect that I wanted to bring up is the importance of recognizing both our political and our personal history with health policy, and recognizing the fundamental nature of the health sector, which is it's a business. And so the Republican bill, whatever it turns out to be, does in fact recognize at least part of that. Probably not very successfully, but the fact is that the ACA is part of our history, and in particular the changes in the way the insurance industry operates. Those are fundamental changes. We're not going back to either 2008 or anybody's strange idea about what 2008 was in the insurance business. We're not going back there. It's not going to happen. That's the role of the Senate, to remind the House that we're not going back there. So, whatever we see coming out of the Senate won't be what you see today. Hard to know what it will be, hard to know when it will be. I think it'll be better in certain ways. I think a lot of people will think it's worse than the current arrangement, but it will be something that can be worked with in implementation, and that's where I think everyone here should remember it's not just the long game in general terms, it's truly the long game in terms of changing policy.
Great. Reed from the private sector?
Yeah, let me vibe off of the word implementation and execution. So remember that in the private sector, it is still the largest part of how healthcare is financed. You're talking about 180 million people here. And so as exciting and as important, and as the policy and the politics issue are, the train is still moving forward with 180 million people trying to find a way to be able to retain health insurance in the private markets. This is a very difficult issue going forward. If you think back to 2000, when the report To Err Is Human came out, which told us what we were losing in America, the equivalent of a giant airplane crashing every day from misadventures in America's hospitals, the private sector went, wait a minute, hold on. What the hell am I paying for? And who's in charge of this? And who's going to address this? And so at the end of the day, the private employers and the agents who work for them, called insurance companies, really had to be the ones to push forward on the innovation to try to get things done inside. The point I'm trying to make is that the pressure on the private sector is intense. That it's not a very polite environment. There's no time for erudite political and policy discussions. It is hand-to-hand combat every day, all the time. The issues of quality and cost are huge. And when you think about the way that insurance works, the margins on insurance are about 3%. The margins in pharmaceutical, like 20%. The difference between competing for insurance business between their competitors is very, very small. And so you have to be relentless in your ability on the private side to be able to show that you can take costs out and drive quality up. My point to you is that it is absolutely imperative that this community understands and gets the need for speed, the need for precision, and the need for practicality from our community. When people like me fight for ARC, and you try to make the argument that the reason ARC has to exist and continue to exist, in fact to be expanded, which I believe in my soul, is because they are providing the evidence that will allow the myriad of decisions that must be made by mature adults in real time who have no opportunity to be fooling around reimbursement innovations. Those were done from the private sector, not the public sector didn't start that. That was the private sector that moved value-based reimbursement forward. They have to deal with value-based pricing for pharmaceuticals and value-based pricing for technology assessment. That have to move forward on consumer tools and population health inside of delivery systems and using data and analytics to guide care management. All of those things were innovations that are living in the private sector. They need the research tools that come out of the funding for ARC. Can you make a direct relationship between what ARC funds and the research being done and real-time change data and evidence that are happening inside of systems today? And you can't make that argument strong enough. It's difficult to do because too much of it is mushy. Too much of it is wonderfully academic, and God knows I love academics. But at the end of the day, the people that are running the trains need to be fed instantly, fed now, because they're doing it under pressure this moment. So I would just conclude by saying that the excitement of this historical moment is that this continues to be our time, but only if we use our time to be really focused and specific about how we supply the necessary evidence, data, and analytics that allow the people that are having to fight these wars without any room for restiveness, erudite policy discussions, and so forth, if we can get that done. We'll talk later about where will the funding come to help you to get that done.
So let me pick up. That's great, Reed. Let me pick off Reed's comment, and I'm going to ask whether it was the Office of Management and Budget or the Congressional Budget Office or the private sector, how you consume the work product of the health services community. I'm pretty sure it's not in a peer-reviewed journal article that is 6 months at best down the path. I hope it's not from a tweet. You know, what's the mechanism that you absorbed knowledge in your staffing of policy decisions that were of such national and private sector importance?
I'll start. So I can actually speak to both OMB. I spent some time at CVO earlier in my career, but Joe should talk about CVO. At OMB, I think it helped a great deal that I had the background already. I was a member of Academy Health. I came in with, a pretty strong background in health services research. I had a colleague at the Domestic Policy Council who had a similar background and was able to say, especially during the budget negotiations that we were engaged in about a year and a half ago, ARC was absolutely on the line. It was not going to make it. And we basically said we will fall on our sword over that because we came in knowing that this was not an agency we were going to let go. There's a conflation of ARC and NIH and maybe a couple of other health care funding agencies by folks who have never stepped foot into a lab. They don't know what, the state, they don't know what HCUP is. I mean, that's not their background. And so having to explain that a lot of what we know, but they may have heard about the checklist when it comes to, our process measure, how we sort of engage in surgery. And you say, well, that was an ARC fund. Our ability to understand and disseminate that was an ARC-funded project. And so you have a little bit more confidence that when you walk into a hospital, patient safety is at the top of mind, and it's likely they're going to work really hard to operate on the right knee or the right side of the brain. That's something that's very concrete. Now, my staff, I had a staff of about 5 different teams, about 10 people each. knew that about me and that I would come in with questions. I would come in with, what do we know about this? Can someone do a very quick scan of the literature? Often the literature is 10 years behind. So to the extent we could pull, whether it's updates, issue briefs, those are critically important because they tend to be much more current. Because if you walk into a negotiation table and, again, you're talking to non-HSR people, you're talking often to non-scientists, you're talking to people with certain, they have some conception of what this ought to look like, and yet they're least educated about our practice and about our work. So you have to come in with something that's not 5, 10 years out of date. But I think that consumption often has to do with the people. So to the extent we can pretty much assume the current team are not health services researchers, I think it then goes back to the point I made earlier. We need to be there. We need to be knocking on doors. We need to make sure that our representatives are trolling the halls of the White House. If you can get in, we need to make sure that, if they'll take me, we need to make sure that our representatives are in the halls of Congress, armed with what we've done, what our research show, what do we know will happen if we cut Medicaid what happens when we block grant Medicaid? What happens when we do per capita caps? We have that information. It's not like it's, I respectfully disagree, Joe. We know what will happen when we change those major policies. So I think we have to bring that to the fore.
Joe?
Okay, well, just to be clear, just because you read something at a superficial level, which I would argue all legislation is written at a superficial level, doesn't tell you anything about precisely how it would be implemented. So in fact, you do need to think about these things. There's a reason why the implementation process occurs through regulations. It's because there's a notice and comment period. You often find out things that you didn't know or that you didn't take into account. And it's not just the knowledge of something that you think you know. It's also the fervor with which the comments come in. In other words, you want to know who's pushing you and how you're being pushed, and you also want to know what direction you're being pushed in. These are all very important in implementing the details of policy, not just the broad brush strokes that you see in all legislation. That's not a criticism. That's the way legislation typically works. As far as how you use research, actually, Joe, it really is those old papers. I don't want anybody to be discouraged that the publication lag in serious journals is somehow going to mean that your work is not going to be paid attention to. But what it does mean is that maybe not tweets, but getting working papers out faster, oftentimes years faster than journals, is a very good idea. But also, and this probably applies to some extent to health services researchers, academic people, but it really applies to industry people. We didn't just try to figure out how some 5-year-old study applied to whatever the current issue was, because the 5-year-old study never really addressed whatever the current issue was. And so we regularly call people who we can't name, people who we think we can count on to have a technical perspective, but with the absolute certainty that when you call somebody from the insurance industry that they're going to have a certain angle on any fact that's going to make you want to weigh that against, somebody from the hospital industry, for example, the warring parties when it comes to finance. And so a lot of what you see stems from information that cannot be revealed publicly. It's usually not written down. It's usually based on phone calls. But it also is filtered through the minds of the analysts at CBO and OMB. And they have their own points of view. Net result is that the kind of estimates you get are, well, I wouldn't go to the bank on them. You probably saw that the last estimate from CBO for the House bill said that there would be 23 million people who would not have insurance in 10 years. But then the actuary's office, which uses exactly the same data and generally uses the same assumptions, estimated 13 million. Who knows what the real number is? But the fact is that there is a huge range of possibilities here for big policy, and there's a lot of judgment involved in these estimates. So the idea that you're going to have instantaneous turnaround of information that you can actually rely on, that's a great goal. But I think that we're all fallible in that sense. We can only do what we can do, but we can do it better and we can work harder.
I guess from the private sector side, this is sort of the good news, bad news story. The good news is that obviously the private sector are huge and voracious digesters of health services research. I mean, you have to, you absolutely are doing so many things that require the best information that you can possibly get. The challenge, of course, though, is that that best information has got to be put into play in real time. And so as you deal with the cost escalation issue, for example, how you are able to put programs together that will actually make a meaningful difference in bringing down costs, which will allow you to price your product in a way that is competitive against others in the marketplace, is a very, very intense activity. But again, remember, you have to have people who can run the math, who can do the numbers, who can say, we will bring down healthcare costs in our market to a degree that will allow us to offer a premium to employers, small business owners who really are going through hell right now. We can say that this will be the price that we will offer you, and we can do that, sustain our business, and stay in business. We have to be able to make those decisions and bet on the solutions that we're implementing. We have to bet on that they'll work, that we can execute, that they'll have the desired result, and that we can go out in the marketplace and say a year from now, we can offer this benefit at this price and be able to compete in the real world. So that's the speed with which you have to use health services research combined with your executional capabilities. The good news in all of that also, though, is that what health plans and insurers have been doing is buying up health service researchers. For years now, for people like United, we have invested, when I was there, invested heavily in bringing health service researchers into the fold. So these people exist inside of the organization. The bad news is that unfortunately, because of the nature of competition, the nature of the way in which data is owned and treasured, and because of the fact that there are not a lot of extraneous people running around health companies who have the time to participate in a lot of conversation, because there are not very many, again, inside of insurance companies, I don't know if you understand it, but they are very small operations. They're not huge operations with lots and lots of people. They are very small operations ultimately. And so the people and the time to be able to contribute that fundamental in-time, real-time knowledge and learning into the diaspora of the health service research conversation is not optimal. And that's something that I think we're going to have to start to address. How can we find a way to incentivize private insurers who have a mound of data, an extraordinary amount of real-world outcomes of implementing solutions? How do you bring that data forward in a public way, similar to the way you do when you do CMS interventions, so that we can add to that database, and how can we make it worth their while? We thought that the taxing that funded PCORI and those sorts of tithing that were forced on the insurance companies would do that. I love PCORI. I think they're just terrific people. But at the end of the day, did the health insurers feel that the tax that was taken from them to fuel health service research, did they get a return on that investment anywhere near the ROI on what they do in-house? And the answer is clearly no, they didn't.
Could I make a quick comment in support of Reed's important points here? In particular, as you said, it's speaking from the insurance industry standpoint, but it's also true for hospitals and organized providers in general. There's real money on the line. They're making serious bets And a key element of being able to handle this is for government policy to make it possible to get out of that bet if it's a bad bet. To be able to allow insurance companies and other people in the health sector the flexibility to make adjustments. Don't want to call it on the fly because, of course, you have to give it time to find out whether it works. But that's really an important issue, which I think is often overlooked in Washington, and it's a real problem. So, in fact, where, in a sense, where's the real research going on? I agree with Reed. The real research is going on in the industry through the insurance companies and to some extent through the provider community, to some extent, and I think a good question that you raised is how do we bring that back to programs like Medicare in particular? I think Medicare has tended to want to tell people what to do, and really the flow of information ought to be coming up.
Let me just give it a good example of how I thought was a good thing. One of the biggest policy issues that are real practical implementatable has been the transition or the attempt to transition from fee-for-service to value-based reimbursement. For the private side of the house, no matter what market you are in, you're never going to be big enough as any private company alone to be able to move the needle, because CMS will always be the 800-pound gorilla in any environment. So you will always try to push and push as best you can, but you'll never be able to dominate the conversation because it's really ultimately going to be Medicaid and Medicare that will ultimately dominate it. So one of the things that was challenging on the private side to push the delivery system to move off of the fee-for-service world and move to value-based reimbursement was, you began to try to say, look, it's time to move. But CFOs of private delivery systems, hospitals, big physician practices, really would always have to ask the question, when will the critical mass of value-based reimbursement be there enough that we can make the capital investment decisions in the data and analytic tools that are necessary to survive in a value-based world? Well, that was, an unclarity for a very long time. And then about a year and a half ago, the then administration comes forward at this leadership of CMS and says, we're going to announce, here is what you can expect in terms of the timetable to get from fee-for-service to value-based. And here are the steps that are the intermediaries, and we're going to be real clear in our signal. In that room were all of the private insurers standing side by side with CMS. This is a great model for getting people's attention, deciding on an important initiative, giving clarity and expectation so that the capital decisions that need to be made by the delivery system can line up with those sort of things. That's what we have to have more of, I think, going forward, and bring these sort of worlds together. The same will be true around the interoperability of the data systems, so that when you collect the data, not only at the clinical level, but as the insurance companies collect it, the employers have their data, you can pull that together and then perhaps create some innovative ways to make that available to the health service research world and use data writ large with large ends that you can really draw some inferences from. So it's that kind of collaborative effort that I think we need as we go forward in this discussion.
And Reed, just picking up on that, the value-based transition, from your perspective in the private sector, where are we in that transition and what would help us accelerate it?
I think, well, first of all, we're still half in and half out. And still CFOs of major hospitals and systems like that still understand that it is still in most, again, you got to be careful when you talk about this stuff because there is no one-size-fits-all. Geographical markets mean everything in these conversations. But in general, most of the people that I talk to still recognize that you go ahead and take the penalty on readmission penalties versus trying to worry about your value base, that it's still better to get those warm bodies in the bed and not worry about the penalties at this point. The private insurers are pushing like hell to change that. You're getting some of it from the Fed. So where we are, we're still in the middle somewhere. What do we need? You need absolute clarity. You have to be really forceful and say, no more fooling around. But if you leave it wishy-washy, it'll stay wishy-washy because there's no real incentive on the delivery system side to really make that change. The second thing you got to do if you're going to have a change, and I think this is very important, is you have to deal with the culture of medicine. It is very hard to get change if it is being pushed and demanded into the delivery system as opposed to the delivery system accepting it itself. So building up the culture of medicine to be able to want to do these things and to understand how to do it is also a very big part. But you don't get that cultural change if there is not a hammer. I know this from 20 years of picking my axe against that rock. You must have clout. Otherwise, the status quo will stay like it is forever.
Desi, you want to comment?
Yeah, no, the new administration just put out the proposed rule for 2018 MACRA, or the Quality Payment Program. We wrote the regs on that last year. This is the second year. So essentially, we now have a year of experience under our belt. And I think that, to pick up on what Reed said, this new rule seems to take into account physicians' experiences so far. They've continued what we introduced, which was called the Pick Your Pace program. Basically, that you can have a glide path into either MIPS or advanced alternative payment models. But essentially, they've looked at and they've listened to physician groups, different professional societies. And I think that the one thing that looks like they did get right is to be as responsive as possible, to think about how they account for cost or resource use, and maybe, again, take it a little bit slowly. Because quite frankly, we don't have the pristine systems that we would like to have in order to hold physicians and physician practices accountable, up to 10, 30% for cost. So I think, among other things, they've taken into account low volume providers. They've taken into account, if you're a rural provider. Now, I think the question will eventually come up, as we exclude more and more physicians from MACRA and Quality Payment Program. What was all this for? Are we truly moving as forcefully as we can towards alternative payment models, or are we sort of half in APM or advanced APM and half out in fee-for-service?
And I think a big issue that's silently in the room is, can we get cost containment fast enough to avoid some of the linkages to consumer price index increases as opposed to medical price index increases in the coming future. Let me ask Joe, this is from an outsider, probably in the swamp, but on the edges.
You're in.
How do you rationalize the fact that basic insurance principles are not in the political discussion? That you can't have no pre-existing conditions and voluntary participation. I don't get to buy car insurance after I wreck my car, but it seems like the proposals are we should be able to buy health insurance after we have a major need.
So, a couple comments on that. First of all, remember, politics must have something to do with it. Pretty sure. Republicans say they don't want to have an insurance company, bail out insurance companies, because nobody likes insurance companies. On the other hand, the requirement for insurance companies to give cost-sharing subsidies remains, and that's a lot of money. In a single year, that's about $7 billion. That's a lot of money. And the solution to that is built into the ACA, which is if insurance companies run short, they can raise premiums, and as the previous administration tried to remind people, especially last fall when they were looking at 25% increases in premium, don't worry about it. If you're subsidized, you're covered, so it's affordable, which is kind of a funny definition of affordable because all it means is cost shifting to other people. We really are rearranging the deck chairs on the financial Titanic here. We've been doing that for a long, long time. Republicans blew it. They could have, in January, clarified their position on the cost-sharing reductions. They really needed to stabilize the market. I think it's not really too little, but it is, in a sense, too late for this year to finally have a clear statement in the Senate bill about extending the payments for 2 years. If one were to make a prediction, one would look at history and say, sustainable growth rate. I think we're probably going to see the same kind of year-by-year adjustments to avoid bad CBO scores. Not just on that, on a lot of things. But on this one, it's almost a no-brainer. Why 2 years? Because it costs too much money to go more than 2 years. So this is not exactly the kind of policy making that you'll learn about in high school. But it is the kind of policy making we've been seeing for decades now.
I want to open up to the audience. If you have a question that you'd like to ask the panel, I'd ask that you approach one of the mics and we'll work you in as quickly as we can. I want to go down our group, though, because it's Sunday morning. You know, there are a few people watching Face the Nation or Meet the Press. What are your successors thinking about today that they're going to have to deal with this coming week? Desi, let me start with you.
So I had my successor at OMB is, he's thinking about a number of things. My guess is number one on his list is whenever we see the final bill. So there's a meaningful difference between a discussion draft and a final draft. As CBO is scoring the discussion draft, if they come out with the score that they don't like, that might, it might end up changing a particular policy around maybe around the edges, maybe something pretty substantial. Whatever happens in terms of what we see, because I think the plan is to vote Thursday next week. What will they then do on the administration's front? So that's one. That's probably a key issue. And he's in lots of meetings, quite frankly, hammering these out. He's probably thinking about Zika. So this is the summer. I'm just thinking about my life last year. Zika, we were fighting for funding. We needed $1 billion to have sort of a comprehensive effort because it was much more of a threat than was originally understood. Zika has not gone away. It's not on the front pages because we have a lot of issues that are making the front page, but that's probably also on his list. He's also, according to press reports, been tasked with coming up with a proposal, an EO or an executive order to deal and solve rising drug prices. That's unusual. So he's thinking about that, and I saw a report of a leaked draft. It's a myriad of things that generally should not be coming out of OMB, but apparently it is. Okay. So those are the three things I can say.
Joe, yours?
Well, so there's really nothing has changed for CBO. So I'm not really going to address what people are thinking about a CBO. There are no surprises. They already know all of the issues that are being considered. They've been working on them for quite some time. However, I can reflect on a job in my ancient past. I ran the precursor to the Innovation Center. It was called by the way, it was HICFA then, and it's HICFA now. But it was called the Office of Research and Demonstrations. And so from the perspective of the Innovation Center, and maybe not the specific individual, but institutionally, they're going to be rethinking what have they done in the last 6 years or so. Partly, it's that it's very confusing to understand what the actual agenda was for the Innovation Center. If you look on their website, the descriptions are really hard to understand, and the same words are used for what appear to be different projects. And I think there's going to be a process of not stopping things, because that's very difficult to do, but reassessing and trying to categorize what are these projects, what are they really aimed at, How are they coordinated? That's been a big problem, I think, that everybody recognizes. They haven't been coordinated very well. And it's going to take years, literally, to sort through that, but they ought to be pushing in that direction.
I see a lot of people with the microphone, so I'll just say I know what they are thinking about. Number one is, how do you increase quality? Number two, how do you take out wasteful costs? And number three, how do you move from managing healthcare benefits to total population health management? Those are the three things that are on the mind of the people who had the job that I used to have.
Great. Let's start with Mike 3. If you would introduce yourself, and I would encourage folks to have a succinct question if possible. Is it on?
Is it on? Yeah, it's on.
It's on.
Is it on? Oh, yeah, okay. Sorry. I'm Bill McQuaid with the Rhode Island Medicaid program, and I think this is a great opportunity for us to bridge the gap between policy and research. And there's always been a lot of professional friction in my career anyway between policy and research. And so I'm trying to challenge Reed as politely as I can when he says the private sector is looking for more timely, more precise research. I can tell you in 30 years of doing it, I haven't met anybody in the private sector or the public sector that was really looking for timely, precise research. They were looking for evidence that would support them doing what they wanted to do in the beginning. So this isn't necessarily a question, but take it as an opportunity for us to work a little bit better together.
Well, first of all, I love the idea of working together. That's terrific. I'm just flabbergasted at the comment, however. I've never, ever met a company of people who had to bet millions and millions of dollars on doing things that they didn't want to get it right, but somehow or another wanted in some weird policy thing to be validated. Man, look, you've got to run programs that have huge stakes. I mean, really big stakes. Are you really trying to suggest that people who are running major American healthcare companies have a pre-agenda that they want validation for versus they want to be precise in what they do and successful in running their operation?
And take their money and they'll increase rates next year and people will pay it.
Okay. Let me offer a little perspective. Because I think
that's not even rational.
No, Reed, I've got it. I've got it, Reed. The issue here is the operating. Wait. I've got it. The issue is the operating term precision. Okay? In the academic world, you want 99% certainty and p-values of 0.01. In the business and frequently the political world, there's going to be a decision, and it's a coin toss. If I can get to 60% certainty or 70% certainty,
I'll take it.
I'll take it. Is that fair on the political side?
Yes.
Exactly.
And it's even more so when you got millions of dollars sitting on the line.
Yeah. Now, let me just real quick, because a lot of people there. And first of all, let me apologize. There is never a good reason to not take advantage of the chance for dialogue together. And so I want to respect my brother for his comment, and I owe you an apology. What I was trying to say quickly is that if I am contracting with a physician network or a hospital network that says that I think that we will pay you a certain amount of money, and that what we need to be able to do, though, is to wrap around that a set of services that will predictably give us a cost profile for that population of people, and that we're going to go to the marketplace and you're going to bet that that decision that you have made and the price you've come up with, which has to be low enough, by the way, to compete with other people that are doing the very same thing. This is very specific work. If you're going to do that, you've got to be on your game. This isn't an erudite policy philosophical discussion. This is business. And so my point to him only was, and what I should have done a better job, was just to say to you, sir, in all due respect, this is not something you're looking for people to validate some pre-existing position. You've got to run this business based on facts and data. And that is all I was trying to get to. But I appreciate the chance for dialogue.
Let's move to microphone 2.
My name is Oliver Fine from Weill Cornell in Manhattan. And I wanted to ask the panel, there's an increasing interest clearly within the public for a single-payer national health insurance program in this country. And although it appears certainly on the national level to be less realistic politically, there are states such as New York, such as California, that actually have substantial single-payer bills. What do you see as the role of health services research in helping those states actually formulate good policies in terms of single-payer?
Anybody want to tackle that one? I'll tell you from a southern red state when I get that question. Here's my answer. If we continue to fundamentally disavow insurance principles, we will kill the private insurance industry and we will end up with a single-payer system. It won't be a voluntary choice. It'll be because we make insurance companies take people with pre-existing conditions and don't have enough healthy people driven in to stabilize the risk pool. Anybody else want to comment on that one?
Well, so, I'd start with accounting, not health services research. California, I've actually forgotten the numbers. I read it in Kaiser Health News, one of those little blurbs, but there's some gigantic amount of money that it would take, and some commentator said, oh, well, it's really not much more than we spend now. Yeah, no, it's a lot more. And the fact is that single-payer system in California would probably mean state income tax rates of 40 or 50%. So you have to think about this. If you want to help a state, you want to make sure that they understand what the consequences are, because it's not just the health system. You want to think more broadly. It's the state or the national economy. You don't want to drive jobs out of your state by driving up tax rates to unreasonable levels.
Let's go to mic number one.
Hi, Charlene Wong, Duke University, Duke Margolis Center for Health Policy. I'm a junior health services researcher in academia, very hungry and eager to put the right evidence in front of the right policymakers in a timely manner. But my question for you all are your thoughts on how we can incentivize academic institutions, journals, to help us, those of us who are trying to create this evidence in a timely way, but also have it count, because if I write a health affairs blog or write an issue brief, it doesn't count the same as writing one of these peer-reviewed articles that, is several months behind, as you all mentioned.
I mean, yeah, I can start. I agree with you wholeheartedly. I think, when I was a doctoral student, the fact that I wanted to go back into policy. Before getting my PhD, I was working at CBO. And when I told folks what I wanted to do, I wanted to go back to DC and do policy, I was a disappointment. And I think because, academics want to clone, and I get it now that I'm one, I want to clone people that look like, do what I do. But at the same time, there is an inherent tension in the incentives and what you're rewarded for as a health services researcher and as someone who might be at the state government or at the federal government in whatever agency. I think the only advice I have is to do your best to bridge the two. An article you've submitted to Health Affairs or any journal, NEJM or JAMA, could also have a portion that you could extract with timely information, make it relevant to a current policy question on the table that you can then submit to a health affairs blog, or you can put out yourself through your whatever institute as an issue brief. And quite frankly, circulate those 2 to 3 pages. Policymakers don't read journals. They just don't. They read the 2-pager. They read the blurb as they're running from one meeting to the next in a hallway so they can remember or figure out what was said recently about a particular question. It's just the nature of the job. So I think to the extent you can do that yourself in terms of bridging the two could be really helpful.
One thing I hope you are doing, and I'm sure you have, is though your whole division march up to the governor's office and say to the government, dear governor, we know you're in deep doo-doo over Medicaid costs, and we're here to help. So I think that they really have to be very direct and be specific. Please tell us, what are the challenges that you are facing? our center will focus on those things because we're state funded and we want to be able to give you what you need to make the decisions that you need to make. So tell us what you want, let us get after it. Although, by the way, we're also going to do some non-applied research so that we continue to develop the methodology and the methods to be able to do complex alternatives to randomized controlled clinical trials when you can't be able to do those in the current environment, blah, 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 blah. So you have to still stay on the basic science of it, but you still also want to have half of your brain saying to them, let us be relevant to you right now. Let's have a meeting. Let's talk about your biggest conundrums, and we'll be here to help you.
And in doing so, no matter how crazy the question is, answer it first before you put your ask on the table. Let's go to 3, and then we're going to 4 next.
And Hal Luft, Palo Alto Medical Foundation Research Institute. Question for Reed. One of your comments I found quite concerning, which was the disappointment that you feel the insurance industry has with PCORI. Because as I was thinking about the development of PCORI, I saw it as the most important piece possible to bring some light on the value of various, quote, medical innovations, drugs, devices, new surgical techniques that all the providers want to do. And the insurers get stuck with paying for it, and if they say, we don't want to pay for it because it's not good, they're seen as the bad guys keeping good things from needy patients. What could PCORI have done to have gained the political support of the industry to get good research out there on what doesn't work?
So first of all, you are terrific. And by the way, I've learned from you and reading your stuff for all these years, and so thank you for it. Please remember that what I also said, and I'll answer your question specifically and quickly, is I love PCORI. So love PCORI. The problem with PCORI has been, of course, is the way in which it was legislated into action. They were not allowed to talk about costs. That's what's so frustrating. So I'm glad that you gave me the chance to amplify that. I should have said that in the comments. So the things that they needed out of PCORI were costs. The fundamental decisions, ultimately, even though everybody understands the mantra quality in the relationship, we needed more on the cost side. And PCORI wasn't allowed to do it because of the craziness in which the political equation that established it. So I think that's really where most of the frustration was. Not that they didn't like PCORI. The private insurers are all over PCORI. Everybody knows them. We love them. It's just a mandate.
Thank you.
Thank you.
And thank you for the chance to clarify. That was a beautiful question.
Microphone 4.
Hi, Samira Kamrudin, Director of Health Services Research at United Healthcare. I don't think I have a question. I just felt a need to corroborate Reed, because when he was talking about United Healthcare, but recruiting health services researchers to come into the company and work from within, I have to respectfully disagree from the gentleman earlier, because we collaborate a lot with academic partners. We have grant funded from HRQ, RWJ, NIH.
So let me ask, if you have a question, that's good. But
well,
we've got lots of recruiters in the room.
It's more of a platform for people to, be able to approach industry more with their ideas and bring something to the table, because we're not closed off. It's not just our interests, at least from United Healthcare.
Great. So an opportunity for engagement.
Yeah.
Great. Let's go to microphone number 1, Shoshana.
Hi, Shoshana Sofair. Reed and others really articulated this chasm. It's not the quality chasm. It's the chasm of the relevance of health services research in the short and medium term to the decisions that people have to make on the front lines. Reed, you spoke in terms of an insurance company. I think also in terms of the delivery system and what research do they need to proceed. So my question has to do with what's the forum, what's the context in which we can actually have a productive dialogue between health services researchers and the delivery system and the insurance companies about what questions we should be asking. And the other critical thing is, when do you need the answers? Because part of the problem is a timing issue, right? So you need this answer. You needed it last week. We can't pull that off. So we're just not that good yet, you know? And so how do we create that forum? How can Academy Health be that forum? You know, I mean, I sit here, I'm looking at Lucy Savitz across the way, who is a champion of the role of the healthcare delivery system in doing research. They're also recruiting health services researchers. This is good. But how do we create that forum? And I really would like everybody to answer this, because the other thing is that researchers need to hear from people whose ideology they do not share.
Yeah. Let me
as well as those whose kind of perspective they don't share.
I know we're right at the end of the time. Let me just really applaud you for that. And I would say that one of the reasons why I came back and joined the board of Academy Health was specifically for that purpose, is to try to help bring more of those constituencies together in a better way. That's why it was so important, and I apologize to the gentleman earlier, that we really do have to make sure that in our thought, word, and deed, the tone and tenor of our conversations must be so respectful that allows for that to occur, and that's why I owed him an apology. So my point to you is that I think that with Lisa and I are certainly going to be talking a lot about that, Shoshana. I think that's the right thing to do, and Academy Health, this is the moment to do it, and I'm going to be busting my cookies to bring that off.
For our questioners that are here, I apologize. We're out of town.
Out of town? Yes, we are.
We're out of time. Let me ask Lisa to come back and ask you to thank the panel for their contributions this morning.